there, trained in Memorial Sloan Kettering in surgical oncology, and continues to work there, and has really is here really to speak to us about his contributions in the field of global oncology. He's really done a lot of work in the space, in the global surgery space, particularly in the field of building cancer systems in sub-Saharan Africa. He gave a terrific talk, a public lecture yesterday about academic partnerships, global collaborations between the global north and the global south, and it was really a fascinating talk about how that is it's a moving target. It's an evolving partnership between institutions, and how to really make sure that both countries are benefiting in a truly reciprocal way. And he gave some terrific examples through his work, particularly with ARGO, the African Research Group for Oncology, which he was a co-founder of many years ago, which has grown into an incredible collaboration between multiple institutions in North America with African nations, and the multiple benefits that have emerged from that partnership in a really truly reciprocal way. So I think today is going to be speaking more about some of the progress they've made together. So I look forward to the talk. Thank you.
Thank you, Solan, for that introduction. It's great to be here. This is my first time coming to Queens. It's been a fantastic 16 hours already. I can see why all of you love being here, and I look forward to bringing my family back one of these summers. So today I'm going to talk about results from the African Research Group for Oncology, or ARGO. I have Isaac's name here as well. Isaac is my collaborator in all of this. He's a professor in Nigeria, and he sends his greetings. I was talking to him early this morning, actually, and so he was eager to have our work presented here. So cancer is a growing problem in lower middle income countries. I'm going to use the acronym LMICs throughout the talk. By 2050, 70% of the predicted people with cancer will be in LMICs, and many of them will need surgery. So as a surgeon, this was sort of an obvious way for me to get involved and to focus on this. This is the first patient that I ever operated on with Isaac. He's a young 25-year-old male. You can see his abdomen's quite distended. He had a very advanced low rectal cancer, and this picture was about 2 o'clock in the morning when we did a diverting colostomy. And this is really what started us down this path of trying to ask questions about what are the differences between cancer in Nigeria and in the US, because he had peritoneal disease. It was different. The pattern and just how it felt and looked seemed different to me. And it's not that common that we see 25-year-olds with locally advanced rectal tumors with peritoneal metastases. So this really started us down this road of trying to figure out what the similarities and differences were. Cancer rates, especially breast cancer, prostate cancer, colorectal cancer, sort of the higher income cancers, are all really rising in LMICs. And there's a lot of social reasons for this. So this was an article in the Times about how obesity had come to Ghana with this rise of fast food and KFC pictured here. And this is a common theme, and I would say 10 to 15 years ago, it became much more of a public health priority. Non-communicable diseases such as cancer, diabetes, heart disease, really a growing problem. So why does this matter to us? Well, I would argue we can't understand the biology of cancer just by studying it regionally. If you ask someone, what is the biology of colorectal cancer? They will likely refer you to the Cancer Genome Atlas and say, well, this is colorectal cancer. But it's not. That's colorectal cancer of white Western European heritage. That's what makes up most of what we consider sort of these global looks at cancer. And it's clear that you cannot say, this is colorectal cancer or some other cancer by studying it in one population. We really need to study it globally. And as cancer rates rise globally, we can learn a lot about overcoming screening and early diagnosis barriers, because those barriers are common amongst cultures, and we can definitely learn from each other. And we can learn about a lot of environmental and cultural impacts on cancer by studying them in low middle income countries. So when I started at Sloan Kettering, I was hired on as staff in 2010. And after a couple of years, we were able to establish that we wanted to create a group at Sloan Kettering dedicated to this. So we created the Global Cancer Disparities Initiative, GCDI, to improve outcomes for cancer patients in sub-Saharan Africa using collaborative research and training efforts. And we have a bunch of goals centered around research, education, and clinical care. And I would say that all three of these are usually wrapped up in everything we do. Like any clinical trial has capacity building and education. Any true research study, there's patient care that happens. Capacity building can happen on the side. So we try and link all of these. And the goals are strengthening in-country cancer research and leadership, implementing cost-efficient early diagnosis and treatment, consolidating regional cancer data, disseminating outcomes to communities, and providing a path for professional development. And at the heart of this is our collaboration in Nigeria. This is myself and Isaac at a conference, and we started the African Research Group for Oncology. We started with Isaac's institution, Obafemi Awolowo University, and Sloan Kettering. And then we grew to have 5 core sites in Nigeria, centered mostly in the Southwest, and stayed with Sloan Kettering. And now we've grown this to 30 Nigerian institutions spread throughout the country. And there's a number of North American sites that have also joined in. 2 Canadian sites, Toronto's just signing on, and Dalhousie is a member. And the goal was to try and create an umbrella organization that we could build infrastructure to start asking a lot of big clinical questions and use this infrastructure to answer these. So our methodology for how we wanted to structure our research, we broke up into these 5 groups: epidemiology, biology, screening, diagnosis, outcomes and treatment, and access. And this is obviously drawn in a circle because these are all related. You could draw lines across as well because everything's interrelated here. So I'll sort of walk you through what we've been able to accomplish with this. So one of the first things was just doing prospective data collection, because if you search in PubMed for cancer epidemiology in most LMICs, a lot of it is modeled off of one country, 6 countries away that happens to have a cancer registry. So all of it, a lot of it's not very accurate because there isn't a lot of prospective data. So we started with prospective data collection, and we started with colorectal and then moved to breast. We had to start with colorectal because we thought it was small enough that we could manage this. Breast cancer is so common that we didn't have the infrastructure to even deal with data collection at the start. So now we can say things like the median age is 53 compared to 68 in the US. Significant number of patients are young. And now we know stage of presentation. And this is just a comparison versus SEER in the US. And obviously, a huge difference in that there's more early stage diagnosis in the US versus later stage in Nigeria. And when we look at survival, we look at 6-month survival of 62%, 12-month survival of 48%. Most of what I do is colorectal cancer, liver metastases, and we talk about curing patients or 5-year survival, right? Even in that setting, in stage 4 patients who we deal with, we don't talk about, oh, sorry, something popped up. We don't talk about 6-month or 1-year survival. So this is obviously screaming for early diagnosis, trying to shift this curve. But having these data are really powerful because now that we're doing interventions, you have to know what the starting point is. So one of the first questions we've asked is, what are the risk factors for colorectal cancer in Nigeria? And this is just sort of a visual depiction of what has shifted in culture. So this is a skinny woman pushing a bike, a lot of produce, rural lifestyle versus modern day Lagos, everybody sitting in a car, sedentary lifestyle, obesity, environmental exposures, processed foods, all these things that come with urbanization. So we built a case control study that we got funding from the NIH for, 600 cases, 1,200 controls between 5 sites. And we're just about at the end of accrual of patients. And half of this was an epi study looking at diet and exercise. And we took the Nurses' Health Study in the US and we worked with Nigerian nutritionists and epidemiologists to adapt that to Nigerian food. So you can see these are pictures. It's a very visual scale that we use about how much patients are eating. And we validated this with food diaries and photo documentations. And we've now started to look at the dietary patterns in colorectal cancer. And this is pretty novel. This is not commonly done in LMICs. Most of these data are from high-income countries. So we were interested in this, especially looking at food patterns, because people eat in patterns. They don't usually eat randomly. So in this case control study, looking at the first 500 cases and almost 1,100 controls, we looked at 3 empirical dietary patterns: diversified, African traditional, and westernized. And there's 3 index-based dietary patterns. So this is brand new data that we just started looking at about a week ago. You may not be able to read around this circle. This is a lot of traditional meats, root tubers, legumes, refined cereals, organ meat, smoked red meat. And these 3 patterns map in very different ways. And we've seen already that the Western dietary pattern is has an increased colorectal cancer risk. We're still working on stratification and modeling of this. But this is our first look at this, and what our suspicion was and our hypothesis was is probably coming true, that there is some dietary associations with colorectal cancer in Nigeria. The other part of this study is we got a pilot from the NIH. The way NIH grants work is once you get one, the rich get richer, and you can apply for these supplements. So we got a supplement that paid for just 30 patients to wear these silicone wristbands that pick up environmental exposures. They wear it for 2 weeks. They bring them back in. They get shipped off to the NIH, and the NIH can pull off all of the environmental exposures. And so this is a very small pilot, and these are brand new data, which shows a difference between cases and controls in some of the things like pesticides, polycyclic aromatic hydrocarbons, organophosphates. I didn't understand this at first as being such a probable risk in Nigeria, because you think of pesticides, how is that playing a role here? Well, we know that some of the things being picked up are banned worldwide and are illegal technically in Nigeria. But if you're a farmer and someone comes up and says, if you put this stuff on your crop, you're going to get 3 times more crops, you're likely going to do it. So it's very unregulated. And we think that we were surprised that there was a signal in this study. This is a tiny pilot, and we can't stratify for everything. It's so small, but this is going to definitely lead to a much larger exposure study, which we're eager to get going. So I'm going to move on a little bit to talk about the biology of colorectal cancer. And one of the things that Isaac and I use as a litmus test is we have a lot of different ideas. Many of them are academically interesting. If we don't think there can be some translation to patient care and patient outcomes in the near future, we just don't have the time or the energy or the capacity to do it. And so when we started to look at genetics, we really wanted to be careful that we weren't just doing an academic pursuit, which would lead to some interesting finding that there's a difference in KRAS mutation status between Nigerians and Americans, which there is. And that's interesting, not really very clinically relevant. But we did want to take an initial stab in looking at some different genetic parameters. So we looked at microsatellite instability and mutations in 159 Nigerian patients. We did MSK impact, which is our commonly mutated in cancer gene panel. It's 500 genes. And we did in a small group, we did a methylation analysis. And I won't show all of the mutational analysis. As I said, some of it's interesting. Not sure where any of that goes in the future. What really stood out was that this very big difference in microsatellite high colorectal cancer rates, 28% in Nigeria versus 8% in Sloan-Kettering. And this matches what's been published from a couple sites in Nigeria and Ghana. So we think that this holds true. In the Cancer Genome Atlas, it's 14%. So clearly much higher in Nigerian patients, 2/3 in the right colon, no BRAF mutations in the MSI high, it's germline predominant. And I'll come back to this in a bit when I talk about therapeutics. As soon as we saw this, we started thinking about immunotherapy, because these are the patients who respond well to immunotherapy, and they don't respond well to normal 5-FU-based chemo. And that is hugely important in a country where financial toxicity is a real issue. Everyone is self-pay. To be offered a treatment that isn't going to work well because of your genetics is even a bigger deal in a place where you're going into financial toxicity, as is your whole family. So this started us down the path of wondering, could we get an immunotherapy trial going? So screening and diagnosis is really at the center of a lot of what we've been doing. Screening requires a high incidence infrastructure to deal with positives and the ability to pay for false positives, versus early diagnosis focusing on symptomatic patients like blood and stool or a breast lump. And we've gone back and forth between these. Our big focus is always really on early diagnosis. We've been criticized inappropriately I think, by people who just don't get this idea in a low resource environment. Early diagnosis is where you have to focus. So we have done some screening studies sort of to prove that screening shouldn't happen. And I'll walk you through some of these. So we spent a lot of this time in colorectal cancer trying to figure out ways to identify earlier stage patients. So we've looked at four things: FIT, blood and stool, the clinical screen, urine metabolites, and a blood methylation panel. And we've done this in average risk people and in first degree relatives and in symptomatic patients. So FIT testing, we did a study that Isaac led us in. This is Isaac and Greg Knapp. Greg is a surgeon at Dow who did a one-year fellowship with us. And this is the endoscopy team there. And Isaac led this study during COVID, did a 3-city study with 2,330 participants. So he gets an immense amount of credit for being able to pull this off. And this was a true screening study. So this was asymptomatic, average risk, 45 to 75, 91% return rate, 21% FIT positive. And that's a very high FIT positive rate, much higher than we see in high-income countries. About 2/3 completed the colonoscopy that they were offered as part of the study. And we found really high false positive rates in the FIT positive Nigerians, with a positive predictive value for invasive cancer of 1.1% and for advanced adenomas of 7%. And these are much lower rates than what we see in high-income countries. And all these false positives were internal hemorrhoids and diverticulosis. So this really led us to ask the question, does FIT and average risk screening have a role? So we would say that this was qualitative FIT at 50 micrograms per ml. That's the highest on the market. You can't get a higher test. It doesn't exist. If it was 200 micrograms per ml, maybe you lose a lot of the false positives. Don't know. False positives where resources are scarce are really a major issue. And the incidence of colorectal cancer in Nigeria and most LMIC, it may just be too low to even do average risk screening. It may be there's a different pathway. So we don't know the reason why, but we can definitively say from this study that there is not a role for average risk screening with this available FIT test. Now, IARC has come to us and they want to do a quantitative FIT study in screening with a very high rate, high detection rate, to see if that removes all the false positives. It's taken us 9 months to even try and find a quantitative FIT machine that will come to Nigeria and be maintained, which is already telling us a lot about the utility of that, I think. So we can pretty much say, for us, hasn't been a role for screening. Now, we're much more interested in early diagnosis. So we got interested in this idea of just using a clinical screen. So we did a study looking at 362 patients, more than 45 years old, with more than 1 week of rectal bleeding. And we thought these are the highest risk patients. Let's first deal with these patients. And we did a study, and Isaac City is a training cohort, and 2 other cities was a validation cohort. And you can see almost 20% of patients had polyps, had cancer, and about 10% had polyps. This is a very high cancer rate. There's no way that 20% of Nigerians over 45 with rectal bleeding have colorectal cancer. This is a selected group who listened to the advert and came in. The median bleeding time was about 6 months. So this is not someone who saw like one little bit of blood. So clearly this is a high number, but this caught our eye. So we made a clinical algorithm adding in, so these are all people with rectal bleeding, adding in weight loss, change in stool, and came up with a bit of an algorithm about this. But our concern was, are we just finding patients at stage 4 disease right before they were going to come in the hospital anyway? And we found, no, actually, there's a big stage shift. So the majority of these patients were stage 2 and 3 instead of stage 4. Remember, I showed you earlier that currently more than half the patients present with stage 4 disease. So there is this big stage migration to 2 and 3 from stage 4, just in doing this, applying an early diagnosis model to high-risk patients. So now the question that we're asking is, can we scale this up? We did this at tertiary hospitals. Can this really be involved in a public health system? So our goal is to decrease delays in diagnosis and increase early diagnosis. A lot of our research has shown that when you look at the different areas where delays are, it's easy to think that the delay is on the patient's end, and that's usually not the case. Patients are usually presenting months and months and months ahead of time before diagnosis. So usually it's a systems delay. And that's what our goal is to try and shorten that system delay. And so we built a pragmatic trial in Osun State, Isaac State in Nigeria with patient navigation. We find out in a month what the NIH thinks of this. This is a 5-year grant that would support a pilot and then a rollout. And it's using This algorithm, so people more than 25, if you have abdominal and rectal mass, anorectal mass, then more than 40 with rectal bleeding and any one of these symptoms or one of these factors. And the way this is going to work, actually, Paul Karanicolas in Toronto is one of our collaborators in this. I did fellowship with Paul, and he's an expert in pragmatic trials, so we were able to bring him in as our external sort of expert on this. It's going to be a randomized step wedge approach throughout the whole state. There's 30 districts in the state, and over a 4-year time period, every 4 months, another 2 district hospitals will be enrolled. So each district hospital will be its own control, pre and post intervention, and there'll be patient navigation built in. We're doing this with the Ministry of Health. This is the first time something like this has been done in LMIC for colorectal cancer, and we're obviously fascinated to know we have a ton of correlative studies that we're going to be using to try and look at this. But this will hopefully tell us, how does this fit into a healthcare system? Now, at the same time as I was focusing on something very practical, which is find rectal bleeding patients and figure out how to get them evaluated, we have had an eye on technology to see, are there things that we can use to help leapfrog over some of these barriers? And so one thing we've done is look to see if urine metabolite testing can work in this situation. So we have an NIH grant with Alberta, and they're a metabolomics center, and they were building a metabolite test for urine with colorectal cancer based off mass spec. And this whole grant is about how do you take that and make it into a point of care test. So we had 650 Nigerians with colonoscopies proving what they had in their colon, and we shipped all their urine to Edmonton, and we found that the Nigerian colorectal cancer patients, one of the nice things is they really added into the data that existed and changed what the metabolites were, which we were all pleasantly surprised to see this contribution from Nigeria. And it's these 3 metabolites were the ones selected in the end and proved in Nigerian and US and Canadian patients. And you can see how this works. So, for example, just one metabolite, diacetylspermine, sensitivity of 87%. We specifically set the specificity at 50% for this test. We feel like if we can drop half of the colonoscopies that don't need to happen, that's clinically meaningful. And then when we add in factors like weight loss, blood and stool, weight loss and blood and stool, you can see things go up. So the clinical factors carry a significant weight here. Weight loss alone has a sensitivity of like 80%, 75%. So it's an algorithm that combines the metabolites and these clinical features. And the way it works is the patient urine is collected, it's processed, and in the end, there's a tablet that tells you a green check or a red X, colorectal cancer, yes or no. We just finished a 75 patient pilot. This is 7 years in, so a very long process working with technology like this. And we were surprised. Isaac and I are pretty agnostic, if not pessimistic, I would say, when we approach technologies like this. The results actually met our endpoint, which was a sensitivity of greater than 80%. So we're now looking to see how we study this in a larger study. At the same time, we're focusing on increasing colonoscopy capacity, because as we do all these studies, we're obviously generating a lot of patients that need colonoscopies. Isaac has a center that has been a sort of the center of colonoscopy in Nigeria for many years, but we're trying to expand that. So this is GIS mapping of colonoscopy access, and you can see all the centers in Nigeria and the different times it takes to get to them. We use a lot of this GIS mapping now with looking at resources to try and identify other sites to partner with. And I think it's really useful as you do interventions to have this capability to geographically locate where needs are greatest. This is a randomized training course and educational trial that's actually happening this week in Nigeria. And the 2 arms randomized the general surgeons and gastroenterologists to high fidelity trainers versus low fidelity trainers for scopes. The low fidelity is just using pipes and tubes on a board in the shape of a colon. So we will have the answers actually in a couple of weeks as to the results of this. We're hoping the low fidelity trainer works pretty well. Now, I've talked a lot about colon cancer. I will talk a bit about breast cancer as well. Years back, when we decided we had enough infrastructure, we expanded to looking at patients with breast cancer. And the story is similar. It's extremely common, unfortunately. It's the most common female cancer in Nigeria. And the mean tumor size at presentation is 10.5 centimeters. In New York, it's probably 3 millimeters. So clearly quite a difference here. And this, again, is same with colorectal cancer, is really screaming for early diagnosis. And how can this happen? So we've, again, looked at some technology. This is the eye breast exam, and this is a handheld device. It tells you tissue stiffness. So in the green box here, there's one little red area, and that would be that area of the breast. There is something under the device that's abnormal. It does not tell you benign or malignant. It just says there's something that needs to be evaluated. This has been pushed out on the market, and a lot of ministries of health have been buying these without, I think, really properly studying this, especially how to implement it. So we wanted to do a study that we thought asked the most important questions, which looking at women who got eye breast, but also had clinical breast exam and ultrasound and mammo. So we could really figure out where does this fit. So we did a prospective study, 424 Nigerian women, 40 years or older, with breast symptoms or asymptomatic high-risk women. And there were 424 enrolled. All of them had, for the most part, 399 had mammography, 424 had the eye breast and the clinical breast exam. And in the end, there was 30 had a biopsy, 15 were malignant, and 15 were benign. So we looked at the results of this. The person doing the eye breast exam was an inexperienced nurse straight out of nursing school, no history with breast cancer evaluation, hadn't done clinical breast exams. And then there was a very experienced surgeon who was doing the clinical breast exam. And we found that looking at sensitivity and specificity on a breast level analysis of any suspicious finding, we found that the results of clinical breast exam and the eye breast were the same. The clinical breast exam actually demonstrated a bit better specificity, similar negative predictive value. Of the 15 cancers, they both picked up the 13 same ones. There were 2 very small ones that neither clinical breast exam or eye breast picked up. So our conclusion from this was this is not a magical device that's going to find breast cancer in all women. It may be a way to extend the quality of an experienced surgeon's clinical breast exam out into the community, which is not a massive finding, but it may be enough to really set a foundation for a good early diagnosis program. So we now have about a 4,000 woman study that's underway, will be finished in a year, where we have done this, put eye breast in with inexperienced nursing staff at community centers around Isaac's facility. Now, similar to colorectal cancer, when we're finding all these patients, you have to think downstream. So with breast cancer early diagnosis, then you have to have some way to get biopsies. And traditionally in Nigeria, there's no interventional radiologists. So woman who needed a breast biopsy was going to the operating room. Costs money, takes up OR time, is debilitating to the women. So our breast radiologist, Liz Sutton and Lei Omashori from Nigeria, developed a training program to figure out how to do mobile ultrasound to do image-guided breast biopsies. So this is supported by the NIH. 2 aims: developing a competency-based mHealth ultrasound-guided breast biopsy training program. And then aim 2 was training 10 of our Argo radiologists to do this. And this was really a mix of blended learning, simulation biopsy, and patient biopsies. COVID really helped us because it forced us to really figure out how to do this well remotely. Aim 2 was training the Nigerian radiologists to perform and clinically implement these biopsies. And we now can look, the median time from first medical presentation to surgical consultation was 41 days, which is below the WHO target of 60 days for breast cancer early diagnosis and much lower than what traditionally had happened in Nigeria. So we learned a lot in doing this study. We made a mistake in the beginning. We actually didn't really partner with the pathologists on this, even though they're part of our group. And there's a big pathology component to this. How are they reading the biopsies? And so now we learned from that, and we're doing a lot of rad path correlation with this. The GIS is also helpful here. So we can see a 30% increase in population level access to breast cancer early diagnosis through this program. We're now rolling this out nationwide, especially in the areas of the country where there are these gaps, where there is not access to this ultrasound-guided breast biopsies. The offshoot of it, and this is just using the handheld tablet ultrasounds, which I've tried in the operating rooms there, works pretty well even for HPV surgery in the OR. The offshoot is there's now a lot more interventional radiology happening. So without us having this part of the program, there's lung biopsies, abdominal drains going in, all with these portable ultrasounds. So we're also interested, obviously, in outcomes and treatment. I mentioned the MSI high rate before. Isaac and I had this push to try and do an immunotherapy trial. And it sounds crazy in some regards because immunotherapy is incredibly expensive. But when we looked at this, we thought almost a third of the patients with colorectal cancer are inappropriately being treated with 5-FU-based chemo. There's a chemo that potentially, immunotherapy that potentially will remove them from needing surgery or radiation in a place where radiation is really hard to come by. And so we wanted to do this trial. It took us years to find a pharma partner. Everybody was interested. It sounded nice. When they got down to the details, they'd say, oh, there's a risk, and what's the market afterwards, and what if it doesn't work well there, and we don't want negative outcomes. So we partnered with BeiGene in the end, which is a Chinese company that's very interested in Africa as a market. Our primary endpoint is evaluating the overall response rate of these patients treated with PD-1 blockade and progression-free survival, overall survival, sort of all the normal endpoints. We originally were doing just the top arm here, which is stage 4 colorectal cancer. And then when Sloan Kettering, when we published about a year and a half ago, big article in the New England Journal, rectal cancer patients, MSI high, treated with immunotherapy, none of them needed surgery or radiation. The Nigerians called me and said, there's no way we're not doing this, adding this in as an arm, especially when radiation is so hard to come by. So there's a second arm we built in of stage 2 and 3 rectal cancers. We're now, it's taken us about 9 months to get through my institution. We're the actual sponsor of the trial. And now we're flipping to the Nigerian side. We've had great conversations with the Nigerian FDA. They're eager to have studies like this happening in Nigeria. We met with the head of the FDA there, and her question was, what's your next trial? Get this one done. We want more trials. We want this happening in Nigeria, which has been great. We're also, there's some very practical questions. So this is Lakan Olasehinde. Lakan is a star junior faculty member in Nigeria. This is him at Carnegie Hall, where he was getting his diploma from a master's that we helped sponsor him in. And he looked at early discharge after mastectomy because he saw in New York, we were sending women home 2 days, 3 days. And in Nigeria, they sat in the hospital for 12 days, usually waiting for the drains to come out. And so he wanted to evaluate what's the safety of sending women home early after discharge. So there was this early discharge group, and then he had some data from before he started the early discharge. And you can see that the age of BMI was fairly similar, comorbidities. The tumor size, again, very large, 8 to 10 centimeters. And seroma, flap necrosis, and surgical site infection rates were the same between the two groups. These percentages are really high if you're a breast surgeon here. But that's because these are fungating tumors, huge masses, really high-risk women. It was a great study. It changed practice, just this 50-patient study. Throughout many places in Nigeria, now women go home on day 2 or 3. Ironically, one of the things that women loved the most was the phone call from the surgeon on day 5 at home. They said, my surgeon cared, he called, he talked to me on the phone, asked me if I was all right. So we learned a lot about what the women liked in their post-op care. And this leads me into patient-reported outcomes. We've really pushed for this to be a major research effort for a lot of our Nigerian colleagues because it's obviously becoming more important in our trials. Now it's sort of a requirement in many trials to build in patient-reported outcome measures. But historically in Nigeria, many women defer or elect against mastectomy, and we really need to know why to be able to address this. So the BreastQ is a patient-reported outcome measure that was created at Sloan Kettering. We took that and adapted it to Yoruba, validated it, administered it with an ERTC questionnaire, pre-op, post-op, and those data we're just evaluating now. I've seen some of the qualitative research that comes out of this, which is fascinating, and I think we're going to really learn about a lot of the barriers and quality of life issues that go along with having a mastectomy in Nigeria. So access is a huge issue. Can't talk about any of this without access. The finances are fairly straightforward. Almost everybody is self-pay. So it is a brutal system for people with cancer. Access and barriers can be quite high. We've done a few financial catastrophe studies, and depending on what your definition is, 10% or 25% of your annual salary. Just looking at one study of 22 women after breast cancer, almost all of them experienced financial catastrophe. So this is really striking, and a significant number altered treatment due to finances. So Juliet Lumadi, who's from Nigeria originally, she's an HPB surgeon, just started at Northwestern in Chicago, has joined our group, joined in Argo, and her and some of the surgeons in Nigeria are initiating an intervention that just started a few months ago of financial counseling, financial navigation, because there are groups in Nigeria who, non-NGOs, who can help provide patients with money. There is an insurance scheme from the government, but it doesn't cover most cancer care. So we're trying to see, is there some intervention that can happen outside of nationalized healthcare to try and help patients through this huge barrier. At the same time, I'm going to transition from research to training, because I mentioned training is a big component of everything that we're doing, and we really look at every research study as, what are the training components. We have some clinical training opportunities and research. Project ECHO is an online Zoom-based way of having multidisciplinary team meetings. So we do that with multiple disease. We have a pathology fellowship that's online, colonoscopy training. I mentioned that randomized trial. And the Sudavar Fellowship is a 3-month observership that brings Nigerian and other African practitioners to MSK. And we created a 5-year research training program. So this is called NCAT. And there's 2 arms to this. One is clinicians. There's a lot of surgeons, radiologists, OBGYNs, pathologists, all interested in improving their research capacity. So they're in the clinician side. And then there's scientists like epidemiologists and statisticians. And we use a Harvard online training program and postdoctoral training. And we're about 3 years into this. So now all these groups are coming back together, and we've started team science training. And they're required to apply for our pilot grants as multidisciplinary teams of the clinicians linked with the scientists. Our breast fellowship has really exploded. This also started during COVID, when we needed to figure out how to do more online training. This is perfect for pathology. Anyone can look at the screen. Same thing for radiology. And these are our first 2 graduates over here, and they're now faculty members in this is starting our 3rd year of the program. And we're also focused on North American trainees. We have a fellowship, 6 months in Nigeria and 6 months at Sloan Kettering. And Greg is from Dow, and Anna Dare is from Toronto. And we have a new program for residents that's fully funded for a 1-year fellowship, where you spend 9 months in Nigeria. We actually have a house that we own that a patient of mine donated money to in her will, and we use that to build a house right on campus there. So there's a great place for residents to live. This is Betty Abreu. Betty is a 3rd-year resident from Toronto. So a big Canadian presence in our North American trainees. So I would argue that cancer care is a global priority, and we can't understand cancer biology, treatments, and culture without studying it globally. Focusing on the workforce and research is needed to improve outcomes, and global collaborations with leadership from LMICs is required to generate regional data to guide care. It's clear we can't extrapolate our data from high-income countries and just say, here's what's applicable in LMICs. We have a huge group that supports us at Sloan Kettering, from the physician's chief's office on down. The NCI now has a Center for Global Health, started about 2010, and there's really more and more funding opportunities, which has helped us, and a few foundations have helped us along the way. This is the last time we were together, last September. We do an annual symposium where we bring about 30 faculty from Sloan Kettering and our other North American sites with all of our PIs in Nigeria, and this is the whole group. So I want to thank you for your time, and I'm happy to take any questions.
In the audience.
Yeah. After that, eye breast.
Yeah.
What technology are they using? It doesn't look like an ultrasound. Is it like thermography?
Yeah, it's not an ultrasound. It has, if you take off the head of it, there's like 12 piezoelectric squares that is measuring tissue stiffness. So you don't feel it, but there it's actually pushing down. And so again, it's not benign versus malignant. It's just there. So the calibration is on like the arm or the buttock as an area with no stiffness under it.
Another question: for the colorectal group, where is this testing being done for the microsatellites? Is that getting sent down from Sloan Kettering or being done?
Yeah, it's a great question. When you start to look at clinical trials, there are so many avenues that you have to go down. We spent 10 years building infrastructure to do our first therapeutic trial. And others have come to us and said, like, oh, we want to do a therapeutic trial in country X. It's like, okay, well, take a step back, because if you can't do prospective data collection with really good QA, have a biobank, you can't even go down this road. You need research nurses, et cetera. Then you get to the pathology and radiology. So for pathology, we've been working for a while on doing IHC staining for MSI. So for about 2 years, we've been focused on this. A little bit serendipity on our end. The head of the surgery lab at Sloan Kettering, Peter Ntiamoa, is from Ghana and worked in Ghana for years and then came to Sloan Kettering. And so Peter is back and forth all the time, and he completely understands both systems, which has been a huge help to us. We also, we bought 2 Motic scanners, and there's one at Isaac's site and one in our Lagos hub. And that works really well for the fellowship, but also works for this trial, because we can say that we can have path confirmation at Sloan Kettering if needed. So the diagnosis happens in Nigeria. We're not doing real-time confirmation. We've said, this is a pragmatic trial. This is the pragmatic side of this trial. But we will have everything uploaded, so we can later on do a batch review. It's the same for radiology, doing reads for response. We've spent a lot of time on the infrastructure of how do you store those images and how can we get assistance as needed from Sloan Kettering radiologists. But a lot of infrastructure goes into that.
But with regards to the breast cancer issue, like, why are you teaching people to do ultrasound guided biopsies when most people present with 10 centimeter tumor?
Yeah.
You could just find people with a 2.5 centimeter tumor. You can do a percutaneous biopsy just by operation.
Completely agree.
Like, you just treat those patients, it'll make a big difference.
So there's definitely agrees. There's a couple of reasons. This was one of the first questions I asked as a non-breast surgeon in the beginning. Like, women are walking in, you can see it from across the room. For a couple of reasons. One, the radiologist didn't have any experience in doing any biopsies, and so we were sort of starting from scratch. The surgeons really wanted to offload this, and our hope was that as the early diagnosis projects continued, we were going to start identifying much earlier stage women with smaller tumors where this was going to be needed and relevant. And so we wanted to do this in real time, and it's much easier to learn to do an ultrasound guided breast biopsy on a 4 centimeter tumor than it is on a 1 centimeter tumor. So the breast radiologist felt pretty strongly, both there and here, that now was the time to start doing this, where the tumors are easy. Even on visible tumors, they're still putting the ultrasound on, learning to have the needle in plane, having the pathologist have to read the smaller cores that they're using. So they thought that the process of doing it now was going to be what was required for the future. But it's a good question, because it's not necessary for half the women.
Yeah, I don't know what the environment's like over there. I suspect there's a shortage of doctors. It's got to be a real shortage of radiologists. You could teach a nurse to do a breast biopsy, corneal biopsy, just by how patient care to use.
Yes.
And wouldn't that be a more effective way of trying to reach out?
So eventually, yes. The task shifting, there's a lot of cultural things that go along with task shifting. And there are some countries where it's pathologists and pathology technicians who are doing a lot of the ultrasound guided breast biopsies. In Nigeria specifically, there's a very strong group of radiologists. There's even a breast radiology society. And they felt very strongly that they wanted to own this. They wanted to take this throughout the country. And then if there needed to be some task shifting, it would come from them once they owned the procedure. And obviously, for externally, it's like, however this is going to work, they are now the trainers, and they would be the one that would then disseminate it elsewhere. But especially as we start to push this out from the tertiary centers, you could see that that would probably be the next thing. Would be how do you have other people doing this, especially in the 10 centimeter tumors.
Thanks. Another fantastic talk. Breast cancer, colon cancer, prostate cancer are the two most common cancers in North America. Lung cancer is the most common cancer worldwide and the #1 killer worldwide. Is there capacity for treating lung cancer, and is there any thought to expanding efforts? I also imagine biology. Biology is different in North America versus Asia, where there's a lot of studies. Any thoughts on that in the engineering context?
Yeah, it's a good question. There is a pretty active thoracic group at a number of the centers that we work at. Smoking is very uncommon, so the risk factors are all quite different. And there's actually a group that has just joined in with us who are starting to look at this. Some of what they come at it from is more cultural and with stigma associated with lung cancers and patient communications. It's sort of the first time that we brought a thoracic group in. One of the things we've struggled with is how do you expand, because similar for cervical cancer and ovarian cancer, and that's sort of the next disease on the list. So the gynecologists have become very active members. I didn't show any data yet, so we're just starting data collection and a few studies in cervical and ovarian. So we're doing sort of stepwise approach as to what we can afford manpower-wise to sort of bring into this research group. But the thoracic surgeons, especially who lead lung cancer care there, are eager to do a lot more data collection and look at some of the genetics of lung cancer there, because their assumption is it is pretty different.
If I followed you, the epidemiology of CRC in Africa compared to the Western world is statistically hugely different. And if I was following you, your suggestion is might be this environment. And of course, modern medicine is skewed to our genetics, white-based genetic. From the patients we have in North America who are not in that genetics, but are the same as Africa, is there any evidence that there's a genetic component to the statistical difference? Or
yeah, it's a good question, and I think I would say we were very early in our analysis of the risk factors of just this one study, so we cannot say this is all environmental. I think it's going to be a component. It's going to be a component that's probably different than a risk factor that we see commonly in the U.S. And in North America, but it's going to be a component of it. The genetics, we did compare African American patients versus Caucasian American patients versus Nigerians, and the African American patients link much more closely with the Caucasian patients versus African patients. I didn't show the data, but if you look at things like KRAS mutations, much more common in Nigerian patients than African. It's sort of stepwise. It's Nigerian, African American, Caucasian, but significantly different between the groups. There's been a couple papers that have been published about African Americans who have looked at different genetic signatures compared to Caucasian Americans, and we didn't see that link with the data that we have from Nigeria. Now it's hard because African American is a term that captures a lot of people, and many will not be of Yoruba or any of the other Nigerian tribes data. We do have in our MSK Impact, which is this commonly mutated genes in cancer, there is now a group working on how do we look at where people came from. It was very blurry in the beginning, like it was Africa, which isn't so helpful, and they're really trying to now nail down on West Africa, East Africa, and South Africa. So I think there'll be a lot more of that we can use for comparisons. We have looked at some groups in the US that have recent Nigerian immigrants, because that would be really interesting. First generation, second generation. We haven't been able to do these comparative studies. We do know even there's some great dietary studies that have been done. A South African gastroenterologist, O'Keefe at Pittsburgh, who shipped 2 weeks worth of food from Pittsburgh and from Cape Town, from a rural community in Cape Town, and they swapped and they studied microbiome in both patient populations for that time period, and it completely switched their microbiome in 2 weeks. So they had like cheeseburgers and fries from Pittsburgh in rural South Africa, and a nice plant-based diet from South Africa to Pittsburgh. So there's a lot of this plasticity that I think we don't understand.
Yeah, thanks for the talk. I was really curious about your and how important it is to establish all the data. When you look on global can, you see all these estimates, they're all crude, extracted. I know a challenge we see in Canada a lot is follow-up. You might have a patient you receive that might go to another province or state, just kind of what happens. And you're generating your survival curves have you found that to be a challenge that you have to work through?
Yeah, at the core of all this is the quality of data, obviously. So we've got a team of about 40 Nigerians that work full time for us, many at research assistant level. We have 3 managers, and we have a REDCap database manager. And we started with Excel. We went to Access. Isaac and I could write a paper just on all of the trials and tribulations of the infrastructure of data collection. REDCap is perfect for this. And so now we've settled on REDCap. We spend a lot of time on data QA. And it's becoming a growing issue for us because, especially with therapeutic trial, you have to have good data QA. Otherwise, you can't do the trial. So we have a whole group of about 5 or 6 people whose all of their job is just data QA. And we pick up various things like, why at one center are we never getting these data? And then when you call and you find out, it's like, well, there's a reason. The clinic is set up in a way that these patients don't come back in on this day when the research assistant is there. There's always these reasons. So sorting through that takes a ton of time. We look at it as one of our top priorities, and so we have personnel working on this. But it is a big issue. We have patients get called quarterly for our prospective data collection, and everyone has to leave. Everyone has 2 cell phones because it depends. Which telecom provider is working better. So we get both their cell phone numbers and a family member's cell phone number, and so those phone calls obviously are helpful, and that's the best we can do. But it has led to high quality data.
So just as a follow-up question, one of the things that you mentioned has to do with visitation, which is very important from an low-middle income perspective. And just looking at how the trainings have been conducted, more of being focused at our tertiary institutions. As your group looked at possibly, looking at training from provincial district level, where patients present first, and then there could be like a systems delay from those provincial district hospitals to the tertiary institutions. For example, as highlighted earlier, whereby the radiologists are being trained to do ultrasound-guided biopsies, yet the patients present with large masses, and in some settings, true-cut biopsies, are done by junior doctors in the districts. And such trainings are now actually being offered to nurses where patients present first before they even approach the tertiary oncology institutions. So I'm just curious to know, like in terms of from your own experience, how trainings can be decentralized to a certain extent through research and or to provincial and district.
Yeah, it's a great question. And the way we've looked at it is trying to study proofs of principle at the tertiary centers to see what works and doesn't work, and then seeing how does this get implemented further out. So for breast cancer, for example, that iBreast study was done based out of a tertiary center in 3 different cities in Southwest Nigeria. We saw the data, and now we have a hypothesis about how this may be able to fit into a healthcare system. And now it's all primary and secondary centers with all nurses who are very inexperienced with breast cancer. And there's been a lot of logistical problems that come with trying to do that, as expected. But we will now have a 4,000-woman study that's going to show us what really is there a role for iBreast in the primary or secondary center. How does it work? That's why we developed this pragmatic trial for colorectal cancer, because our interest all along has been, we know that if we focus a study on the tertiary centers, we will identify this small number of patients who are at super high risk for colorectal cancer, and there'll be a stage shift, which is great. But for this to really have impact, it needs to be at a much broader, eventually, hopefully national level. It's going to take 4 years of this whole trial to figure out how does that happen. And we're going to learn so many things that we don't expect, I'm sure, in doing this. We're building patient navigation in. How is that going to work from the farthest away reaches in the state from the tertiary center? We know transportation is a barrier. With patient navigation, is that helpful? There's so many questions about this, but I agree with you. I think it's easy to do things at the tertiary center, and then the bigger question is implementation science. How does it fit into the healthcare system? And that's where we're getting to now, having done the earlier tertiary studies. So hopefully in a few years we have a lot more questions, a lot more answers on that.
Peter, I'd like to ask you about Argo. You mentioned that you're now getting numerous North American partners, hospitals, institutions that are partnering with you in this organization. What is Argo looking for in North American partners? What do they bring to the group, and what's involved in becoming part of the group? And what motivates some outside institution to want to participate?
Yeah, so far the outside of Sloan Kettering has been sites where people who were fellows with us went. So Anna Dare is in Toronto, Greg is in Dal. We have a woman, Anya Romanoff, who was a breast surgeon at Mount Sinai in New York. And we have some collaborators, Albert Einstein in New York. So there's been these personal connections. And what we ask is a couple of things. So one is to realize that this is the leadership structure is we're really trying to focus this on the Nigerian leadership. And so this is not any of our institutions coming in and saying, here's how it's going. So part of it is just understanding the culture and wanting to participate in that. We do ask for a specific donation, which is a $10,000 in kind per year. So it can be like right now, Greg and a colleague are in Nigeria and they're helping run this colonoscopy randomized trial. And they support one of the pilot grants every year. So it's not, you don't have to hand a check for $10,000 to Argo. It can be in kind in research support, fellowships. So Greg, for example, at Dal, they do a lot of scoping and he's really trying to help with colonoscopy capacity building. And we sort of said, okay, great for Dal to sort of take this on our side and to be the lead from North America on that. At Toronto, Anna has a lot of expertise in health economics. So she started a health economics working group within Argo that all the financial toxicity stuff is coming out of. So it's bring something to the table, contribute to any of the buckets, hopefully add a new column to all the research studies, and that $10,000 per year of in kind is how we develop this.
It's interesting. Historically, we've always taken, we have our clinical practice guidelines, evidence base, and kind of apply them. There's a structured approach to how we deal with cancer, and very regimented based on solid science. And historically, we've kind of tried to adapt that in other contexts that isn't necessarily true. We show lots of data to say that you can't just adapt and apply what we've learned here to that context, and well beyond just the financial and clinical, but also biological differences, right, that we're uncovering more and more. And then we also have the ASCO resource strategy guidelines. So when we're in a resource constrained environment, there's certain things you just can't do, even if it makes sense at a biological level. So I'm just wondering, as more data, as we learn more about these differences and challenges of clinical and biological cancer care, how is this data being translated into? How do you see the future in terms of practical applicability, especially in a setting that's resource constrained, where you really have to know where is the biggest bang for the buck? Where do you put your efforts? Is it in screening? Is it in immunology, right? And immune therapy, which is very costly, and ethics around that.
Yeah.
If you're uncovering that immune biology is helpful, but it's unaffordable. Because even now, the basic 5-FU-based chemotherapy is putting 78% of people in financial toxicity. How are you going to fit that in, right? And so we have the resource stratified guidelines that help contextualize all this, but still, it's the practical applicability of that in these environments is extremely challenging. It's great that we're learning more, but how do we actually make this useful for the populations that we're learning?
That's a great question, and obviously a very challenging question to have an answer to. We were very interested in guidelines because a lot of groups have made guidelines. It's very easy to make guidelines. We can sit in a room here, even without anyone in Nigeria in the room, and make guidelines. And very few people are studying the implementation of guidelines, what's wrong with the guidelines, and is there even a role for these guidelines? So I didn't show it here, but we have a group working on breast cancer guidelines. And this is a 4 or 5 year project. We're about a third of the way into. So the first question was, who uses guidelines and how? And what parts of the guidelines do you use and why don't you use them? And what's missing from the guidelines? And we have a lot of negative data that we're collecting about the guidelines. And this is the resource stratified guidelines. I was surprised. My bias was that if you ask someone, do you use guidelines? Everyone's going to say yes, right? If you ask me, of course I do. All guideline concordant care. But people were actually pretty honest. And a lot of people don't reference the guidelines. And we know from our prospective data collection how patients are treated. And so we've looked in breast cancer and said, there's a significant number of patients who are treated outside of guidelines or non-guideline concordant care. And we know where that is. Surgery is usually the easiest part. Most people have access to surgery, but often in the chemo regimens and getting ER/PR status, all these things often doesn't happen. So our goal in this study was to try and come up with some conclusion about what is even the role for guidelines, even looking at resource stratified guidelines, which what we all assume is what the appropriate guidelines are, but they aren't being used. So this is our first stab at this. So far, it's been really interesting to see all of the negatives that are coming out with guidelines. So I don't have an answer yet as to what's the output of this, because guidelines are important. But more important is some sort of guidelines that are actually implemented and change outcomes. And that nobody's looking at the outcomes. Everyone's just putting out guidelines. So this is our first real look at the outcomes of it, which I think is going to inform a lot. You mentioned the immunotherapy, and we struggled with this at the beginning. Like, should we even be focused on this because of the cost? And how would you add something like this to guidelines? And we thought it is such a game changer for patients, and it is the appropriate way to take care of someone if you can, that we needed to do a first study to show that it works. And then it's going to be a ton of advocacy. Going back to HIV, when there was global work to try and drop the price, and here with Common Sense Oncology, a lot of this comes out of Queens about the insanity of the price of pharmaceuticals and how that is such a barrier to access. Immunotherapy, if we show that the data are impressive, then it has to lead to advocacy, which is something new for us. But we didn't think that the daunting barriers to using it in the future were enough to not do the study, because we know that this can be the right treatment for patients.
Any final? Thank you very much for being here.
Thank you. Thank you.